Good afternoon. Welcome to the Brain Injury Association of New York State's webinar, Veteran-Directed and VA Home-Based Services, Opportunities in New York and Beyond. I am Carla Giovignello, Brain Injury Training and Services Project Director here at the Brain Injury Association of New York State. Thank you for joining us. Before we begin, just a few housekeeping details. Questions can be submitted during the webinar via the question text window or by clicking the hand raise icon. Both the hand raise and question text box options should be visible to you on the GoToWebinar toolbar on your desktop. If you are having any trouble viewing these options, please contact Citrix Tech Support, and the number is 1-800-263-6317. Again, that number is 1-800-263-6317. This number should also be visible on your toolbar. Right down at the bottom in the chat box. Please be reminded that if you are using the hand raise icon, you are prepared to have your audio turned on to ask your question, and you will not be muted until after the question is addressed. Dianne will do her best to answer questions in the order that they are received. Any questions she is unable to address may be submitted via email to the association. We will be recording this webinar session, and we do plan to post it along with the PowerPoint slides to our website. For those of you that don't know, our website is www.bianys.org. Information about contacting the association and viewing the webinar will also be provided in a follow-up email after the webinar has concluded. It is now my pleasure to introduce our webinar presenter today, Dianne Kayala. Dianne is the Director of New Initiatives with the National Resource Center for Participant-Directed Services, where she leads the Veteran-Directed Home and Community-Based Services Project and Innovations Grants. She was formerly the Administrator of Adult Medicaid Services in Rhode Island, including all long-term services and supports. She served on the Executive Committee of the National Association of State Head Injury Administrators for 5 years and was the Program Coordinator for the Intensive Rehabilitation Unit of the Memphis Mental Health Institute. Dianne is also a member of the Board of Directors for 2 nonprofit disability organizations, including the BIA of Rhode Island. So Dianne is here with us today. Before I turn it over to her, I would love to do a quick poll with the audience just to see who is in our audience today. So I'm going to launch that now. So I'll give you a few seconds just to answer. All right, I'm going to close the poll now. And we have a nice mix today. A lot of individuals that work with TBI survivors and a lot of individuals who work directly with veterans through the VA. Healthcare professionals, it looks like we have a great turnout. So I'm going to turn it over to Dianne now, and thank you all for coming.
Great, thank you so much, Carla. As Carla mentioned, we're going to spend some time talking about the Veteran-Directed Home and Community-Based Program, as well as some of the other veteran home and community-based service offerings, particularly those in the long-term care services and supports arena. The Veterans Administration and the Administration on Aging first met about 4 years ago to start planning this veteran-directed program. Today I'll discuss this program and some contextual background that I hope will help you both in referrals for veterans with brain injuries and also letting you know potential collaborative opportunities that may be coming up. Apologize, having some technical difficulties getting my screen moving here. Okay, I'm sorry. The overall goals for today are we're going to look at try to help everybody understand a little bit better the Veteran-Directed Services, the national policies and procedures, to understand general Veteran Administration home and community-based services, current trends and some of the forecasting for the Veteran-Directed Program and its expected growth over time, and then of course to talk a little bit in more depth about the applicability for those with brain injuries and as well as brain injury associations and professionals working with people with brain injuries. As Carla mentioned, please feel free to put in questions at any time. We will do our best to answer them as we go along, and if we're kind of in the middle of something at the moment when your question comes up, be aware that they will get addressed at latest after the session is over with. So the Veterans Health Administration, and many of you may be aware of this, is a national health system that has about $50 billion in annual expenditures, so it's quite large. There are 21 Veteran Integrated Service Networks, also known as VISNs, and these are kind of the regional offices. Within these regional offices are 152 VA medical centers, and those are kind of the hubs of the medical services for the VA. The medical centers also are supplemented with 800 community-based clinics, and those are particularly common in some of the larger and more rural states to try to make availability of veteran services within reasonable commuting distance. The VA also directly operates 135 what they call community living centers that are what most of us probably know more as a nursing home type setting. And there are also 278 veteran centers for readjustment counseling in particular. Most of the VA medical centers have some form of specialty. That might be TBI, might be spinal cord injury, or something else. Veterans with service-connected disabilities have first priority for VA services, and certain levels of service-connected disability entitle veterans for these services at no personal cost, regardless of what their income is. Any qualified veteran, however, even if they don't have a service-connected veteran, can be qualified for many of the VA services. However, if their income is at certain levels, they may have a co-payment that they have to pay. Home and community-based services are in this category that is basically available to any veteran within certain income ranges. And the Veteran-Directed Program in general does not ask for any kind of co-payments. It's basically just a program that's offered to people who need it. The VA is very much a medically oriented system. It really does struggle some with long-term support needs. I know we've been working with them for probably about 3 years now, and we've certainly heard some people who really even question whether the VA should be in the long-term services and supports business, which is a little ironic considering how many veterans have permanent disabilities and certainly need supports. However, you know, there is sometimes a little bit of a conflict, or sometimes there's a little bit of a reluctance on some of the VA staff to really think in terms of people needing supports, especially those within the home. I would add, though, to that I have never worked with a VA staff person that, to me at least, didn't seem to have an incredible dedication that the veterans they serve get the best possible care. The Veterans Affairs long-term services that are offered include home health services. This is pretty traditional. Mostly they work with Medicare certified agencies, home health agencies. Sometimes we'll work with the Medicaid, sometimes called homemaker agencies that aren't quite as highly certified as the Medicare ones are. They also offer hospice. Of course, in many cases, Medicare is the primary payer for hospice-type services, but the VA will pay for hospice. Respite is a very large program for the VA, and they're really trying to expand on respite. And approximately a year and a half ago, Congress actually passed a bill called the Caregiver Bill, which has led to a caregiver program. And what this is for veterans who have been injured through a service-connected issue since 9/11, so since 2001, are eligible, if they have severe disabilities, for their primary caregiver to receive a tax-free stipend, and also to basically the family receives pretty much unlimited respite type services. So this is a really important program. We're not here to talk about this today, but if people are not aware of it, they certainly may want to be. The Adult Day Health Services, again, is a pretty common service that's available. There are a few that are run actually directly by the Veterans Administration. However, most of them are community-based, and the VA will contract with community providers to provide that. There are PACE sites, which is the program for all-inclusive care for the elderly, and the VA does pay for that as well. In many instances, they'll pay what would normally within a state be a Medicaid share of the PACE arrangement when a person isn't eligible for Medicaid, and then Medicare will put in the Medicare share of this. And the PACE program is basically an integrated health and community service program for people who have, needs for personal care assistance of some type. And then we come to the Veteran-Directed Home and Community-Based Services Program. And this has been active since February of 2009. It's all been special funded. So to date, it's been very much a slow development based on the amount of budget that was allocated to the program. It's a program in which a veteran is allocated a dollar amount or a budget in which they can manage their personal care needs. They can do this to actually purchase workers. It can be family, it can be friends. They can also purchase things in the community, for instance, snow plowing during the winter time, or they can purchase things like perhaps a microwave oven if they have difficulty, for instance, remembering to turn off a gas stove or things of that sort. They do have help to do all this. We'll talk a little bit more in depth about this, but there is a counselor, a consultant that's available to each of the veterans to help them kind of figure out how the budget can be best met to meet their individualized needs. And then finally, in the long-term services and supports arena are the nursing homes. And the nursing homes are only available in the VA system for the most part to veterans who have a service-connected disability. Now, there are exceptions to that. A large number of nursing homes are actually operated by states, and they're called veteran nursing homes. And mostly the state nursing homes have their own regulations on who goes in and who doesn't. The state-run VA nursing homes are mostly actually funded by the VA. However, the state does put some funding into it, and but the VA criteria is generally the one that kind of rules who comes in and who doesn't. There are a number of VA-operated nursing homes, as I mentioned on the previous slide, and then there are a number of people for whom nursing home services are purchased in the community. Let's see, I think we have a question here, so let me go up to that. I apologize because it's kind of hidden on my screen and I'm having some trouble seeing it. Okay, somebody is asking, are there intensive in-home case management services offered? And yes, indeed, they have what's called home-based primary care. I haven't really worked directly with that program very much, but it's an entire treatment team that works with individuals in the community and will go to their home. And generally it's people, I know they have a number of set criteria for who's eligible for that program, but it is directly managed and run by the VA, and that doesn't certainly include in-home case management. Okay. Apologize. The map here shows where the veteran-directed home and community-based services are located currently. The dark purple ones are those that are active, the states where there are active programs. Now, I do need to caution you that just because a state has an active program doesn't mean that it's active statewide. What happens is an aging network agency, whether it be an area agency on aging or a state unit on aging, will contract with individual veteran medical centers to get the programs up and running. In Michigan, it actually is a fully statewide program by now. There are, I believe, 4 medical centers in Michigan. That could be maybe 3. And each of those medical centers contracts with several area agencies on aging to run the veteran-directed program. Another state model is, for example, in New Jersey, where the state is the one that actually contracts with the Veterans Administration. However, the actual individual area agencies on aging do the supports for the individual veterans. Each of the agencies, and again we'll talk a little bit more about this, are supposed to be working with disability agencies within their states. And hopefully some of you are familiar with the Aging and Disability Resource Centers, because that's often kind of the structure around which the veteran-directed program is actually implemented. As of mid-February of this year, the status of the programs are that there are 22 states and the District of Columbia that are active. There are 36 VA medical centers that are active within those states. We have 85 aging network agencies that have provider agreements with different VAs, and there are a little bit over 1,000, 1056 veterans to date have been served in the program. Unfortunately, only 180 of those veterans are under age 60, so there's still a lot of work to be done to be sure that people of all ages, of all disabilities, are sure to get access to this program, because it is intended for anybody who may be in need of in-home supports, who wants to self-direct. The referral criteria for the program are that the veterans can be referred from any source. So if any of you are working with a veteran who you think may be a good candidate for the program, you can pick up the phone and call the VA yourself and refer that person, or the person the veteran themselves can pick up the phone and call, or family members. However, the VA program coordinator, the person who works at the medical center and who's designated as the coordinator, is the one who finally determines whether an individual is eligible for the program or not. And the criteria they use to determine whether somebody is eligible includes enrollment, that they have to be enrolled for care in the VA system. Now, they can enroll for care after they make their own referral, but they won't be able to start services until the VA recognizes them as eligible for services with the VA. That's basically showing verification of service. The person must also have risk for nursing facility care. Many of you are used to this, I'm sure, with Medicaid programs at the state level. And thirdly, another one is that the veteran and or their family working with the veteran are choosing to have this self-directed model, that it be managed within the family. A veteran does not themselves have to be able to self-direct. They can designate somebody to do that on their behalf. Most of the veterans are referred by the VA itself. The home and community-based services in general are pretty poorly funded, and the Veteran-Directed program actually gives people a much higher budget allocation than traditional services within the VA system. So to date, there have been a number of people referred to this program, largely because they had such high levels of need that the traditional services weren't meeting those needs. You know, a lot of the medical centers, for example, if a person is getting home health agency services, a lot of the medical centers will give everybody, say, 4 hours a week, regardless of their level of need. So a person who's fully quadriplegic might be getting 4 hours a week, as is a person maybe with kind of a mild or moderate brain injury who doesn't have physical needs. The Veteran-Directed program certainly has taken on, we're recently just working on a sustainability study, and we got some data in that's showing that the people in the Veteran-Directed program are quite a bit higher acuity than people in general who are receiving traditional services. The way that the VA determines whether a person is in need of nursing home services are, of course, the criteria very much spelled out. So if they meet any of these criteria, 3 or more activities of daily living or ADL dependencies, having a significant cognitive impairment, if a person's receiving hospice, they're deemed eligible for supportive in-home services, or they can have 2 ADL dependencies and 2 of the following criteria, which are needing, ADL assistance, that they're recently discharged from a nursing facility or nursing home, and that discharge was contingent on the ability of them to receive services in the home. Certainly a recent discharge from an inpatient rehabilitation, or whenever any kind of discharge is contingent on home and community-based services. Even if that veteran wasn't in a veteran medical center, that would still be a valid criteria for this program. If a veteran is 75 years old or greater, they would also receive consideration. A high level of hospitalizations or outpatient clinic and emergency room visits are also, of course, considered to be a good criteria. A diagnosis of clinical depression, and people who live alone in the community. And these are just all factors that go into that decision on whether or not a veteran is eligible for the program. And then there's always a catchphrase that even if a veteran doesn't meet all of the criteria they need to meet to be in the program, the VA can make a clinical determination that this person needs to be on the program regardless of that. So if you know of somebody that you think would be a good candidate, it certainly is worth some advocacy in terms of talking with the VA of why that individual really needs some of this service. The readiness criteria, now this is where we'll talk a little bit more about the details of what the program is. Again, at this point in time, it's all aging agencies. Everything in the procedures talks about aging agencies, and part of the reason for that had been initially that the the Administration on Aging had approached the VA to even start up this program, and the VA really hadn't even considered it up till that time. So the first step that they did was to make this a partnership between aging and the VA. However, that being said, there are certainly regions where there may not be an aging network agency even interested in the program. And secondly, that it's very important to understand that the Aging and Disability Resource Centers are a responsibility to be working with people who are expert in disability issues, and certainly brain injury associations would be one of those, in order to adequately serve people with disabilities in the community. So if you aren't already hooked up with the Aging and Disability Resource Centers, that would certainly be a really important step to take in order to be more involved in this program. I also will add that I know the VA has a lot of interest in doing more partnering around brain injury specifically. And in that instance, I think the best contact would probably be with the VA central office in terms of, presenting ideas. And, I think that probably the best way to approach that would really be to think through what kind of proposal you might make to the VA, and also be aware that it takes a great deal of time, unfortunately, for things to happen in the VA system, because obviously things have to go through channels before they can be approved. So back to the readiness criteria and this particular program. The center I work for at Boston College, we have a contract with the Veterans Administration, and our role is to go in to each of these individual locations and do what we call a readiness review and make sure that they have all the components in place to actually be able to implement this program. And so the components that we look for are the Aging Network people are expected to, do the assessment and assist the veterans in planning out how their budget will be spent, on deciding either for themselves or with their representative that they may designate, what kinds of goods and services they may want to purchase, to think a little bit about family caregiver needs. One nice thing about this program is that, for instance, a caregiver, if a caregiver needs some training or whatever, the budget can be used for that training. If it's something that's really for the benefit of the caregiver, it can be purchased, as long as, of course, it's also of use to the individual with the disability. The Aging Network is expected to help veterans manage their budgets and to hire and supervise their own workers, including family or friends if they wish. They, certainly will have help purchasing items or services needed to live independently in the community. And the way that's done is that each of the Aging Network agencies has to either provide themselves or work with an entity that does financial management. So the financial management entities actually do things like process payroll, withhold taxes, pay workers' compensation for workers, and also pay for goods and services that the veteran has had approved in their plan. The Aging Network people are responsible for making sure there are support services provided. In some instances, for example, in Minnesota, they actually contract with an independent living center that does the support services, and a partnership in Vermont has involved the Brain Injury Association a great deal in all of the development and implementation of the program. So there are some different unique ways that it's being done at individual site levels. And the veterans are also able to use traditional service providers, if they wish, to supplement the community-directed care. In general, because the VA can directly contract with home health agencies, and the home health agencies pretty much do the service coordination and care coordination for those veterans. The VT-HCBS program does not allow a veteran to just use agency services. They have to at least self-direct some part of their services, although an agency is often a good backup to them if a worker ends up quitting suddenly or becomes ill or for some reason is not available to work. So, all of these criteria we look at, we have this whole readiness review that is managed. And some of the goods and services that people are able to purchase, we try to keep it really flexible because obviously, from one individual to the next, what they may need or not need is going to really vary a great deal. So instead of making up a list of this is allowed and this isn't allowed, the VA came up with some general policy guidelines. So, any kind of goods and services. Now, this could include things like a person may choose to use a local laundromat to do their laundry versus paying a worker to do laundry at home. It could be things like snow plowing I mentioned earlier. It could also be ongoing purchase. For example, the VA buys everything that they provide directly through contracts to the lowest bidder. So in a couple of regions, people have complained that incontinence products, for instance, were really of bad quality, and veterans would just, it just didn't work for veterans' needs. So some veterans will use some of their budget to purchase a higher quality incontinence product. So anything of that sort is certainly allowed. It does need to be related to the veterans' identified needs and outcomes. And again, in this kind of program, the veteran is the one who is identifying what are their individual goals and how this plan is going to be used to meet their individual goals. The second criteria is that collectively whatever is purchased or used is a feasible alternative to an institution. I'll give you an example. I know somebody wanted to paint their house. That would certainly not be an allowable purchase because it has really nothing to do with the disability, the reason the person needs personal assistance. It's really something totally unrelated. So the basic rule of thumb is that it has to be related to the disability and a functional need that the individual has. The purchased good or service needs to be the least costly alternative that reasonably meets the needs of the veteran, and of course that it be for the benefit of the veteran. Now, like training for caregivers, respite and things like that, even though they may be initially directly for the benefit of a caregiver, it's certainly considered to be for the benefit of the veteran as well, because of course it helps people manage the care a little bit better to have some respite. The goods and services, if all those other criteria are met, they've kind of added a few more little items here. One is that this should help to maintain the ability of the veteran to remain in the community. So this covers things like a ramp, or it can cover different home accessibility type things. It might cover things like transportation, so a veteran can reasonably get out and do recreational things, or even go shopping and do things of that sort. Another one is that it might enhance community inclusion and family involvement. Again, accessibility can be part of that. To develop or maintain personal, social, physical, or work-related skills. So the idea of this program is to look at the person holistically and the number of different kinds of things a person needs to do in order to be happy and content in their home environment. It also needs to in some way decrease, it might qualify if it decreases dependency on formal support services. For instance, if a veteran doesn't have a washing machine in their home, but they could do laundry independently if they did, then a washing machine might be a purchase they could do with their budget. The program needs to increase the independence of the veteran and increase the ability of unpaid family members and friends to receive training and education needed to provide support. So this would be in the case where, say, a sibling is going to back up or needs to have some training and education. This could actually pay for a course for somebody to go to. And it isn't just unpaid. That was actually changed fairly recently, but that can be an unpaid or paid caregiver for the veteran who can receive training and education as long as it's related to the veteran's need for services. The veteran service organizations or the VA itself often will take care of traditional home modifications like ramps or adaptive equipment, you know, certainly things like wheelchairs and even fairly sophisticated technology. So the veteran-directed program is often geared towards non-traditional items. As I mentioned, the washing machine, microwave. Recently, we've seen a lot of people using GPS systems for a family member who might be prone to kind of walk off and maybe get lost, or even just wander off and not really think too much about it, so that they can be located quickly. It does need to be disability related, but it can be very creative and flexible, and we have seen a number of different things purchased through the program. So the benefits to veterans with brain injuries, you know, I think it's probably pretty obvious. You probably know better than I do what that is. But it certainly is a much more flexible way to approach people's needs. I'm from Rhode Island, and I know in Rhode Island a number of years ago we had a nursing home transition grant that really targeted people with TBI. And we found that because the workers could have such specialized training to an individual's needs, that there could be, it could be a much more appropriate solution than to have a home health agency, for instance, come in and assist a veteran. We had one individual in Rhode Island who had tactile defensiveness, and so he had to be approached in certain ways or else he'd flail out, and it was just part of his disability. And they were able to, the family and he were able to find people that would work very effectively and well with him, and they were able to maintain an ongoing relationship. So that's certainly one of the types of benefits for this. The budget can be used, and the VA is actually not too bad around, they're generally pretty good about providing cognitive therapies and other things, but it can provide things that may not be covered in other means that are for the benefit of that individual. People have done things like some of the non-traditional supports, acupuncture, Reiki, you know, some different kinds of alternate therapies with budgets. The work is certainly specified by the person with brain injury and or family members, representatives, and so therefore it can really facilitate community inclusion. If the veteran wants to go to a class or wants to you know, go to a worship service on a weekend, or, you know, just wants to go to a movie or something, that this certainly can support that much more readily than a more traditional kind of program would. And finally, we had one of the kickoff meetings for this program. We had a Sergeant Wade who came and spoke with us, and his wife as well. And Sergeant Wade is a veteran who had a severe brain injury. And he's ambulatory, and he loves to run and work out and everything. And he was able to with their budget, they were able to purchase a GPS system for him, first of all, because sometimes he would just get really frustrated and just go outside and start running, and then people couldn't find him afterwards. And then what they also did was they were able to hire somebody to run with him every day. So he was able to get out and run, and actually run several miles every day. And of course, there aren't too many home health agencies that are really able to provide that sort of support for the individual. You know, I think one limitation of the program, however, of course, may be that a veteran with a significant TBI may need help managing services, and if they don't have somebody close enough to do that, who really is going to act on their best benefit, then I think that can be a limitation of the program, where people unfortunately need to have a little bit more structured service. So how to get involved, you know, as I mentioned, talking with local I know there's a question here, so I apologize because I can't read it, so I might ask Carla to jump back on in a minute, but I'll finish through this and then we'll go on to the question. So getting involved, talking with the local aging agency, and that would be either the local area agency on aging if you already know them, aging and disability resource centers, and if you don't already have any kind of connection there, probably going through the state agency would at least be a good starting point, and they may be able to link you up on the local level. I do want to mention that under the, well, providing it isn't knocked down by the Supreme Court, the Affordable Care Act allocates a lot of new funding to the Aging and Disability Resource Centers, so it certainly might be an opportunity for brain injury associations to work with some of these. You know, certainly we all know that there often isn't a lot of knowledge and expert knowledge around brain injury, and that certainly may be a good way to help make sure that it becomes spread a little more. I did mention before, I know that the Brain Injury Association in Vermont works a great deal with the Aging and Disability Resource Center, so that may be one model for that, and there certainly may be others that I'm just not aware of. The VA Geriatric and Extended Care Coordinator at the local VA medical center is also a good resource to you. If you call the medical centers, everyone is structured a little bit differently, but you can either ask for, sometimes it's just a social work department that you would speak with, other times there's somebody specified to be in the geriatric and extended care coordination department. But if you just ask for social work, they would be able to connect you with the appropriate person. As you saw on the map, and as will be posted on the website, it is not yet in all states and not within all locations, even in those states where it is there. The VA has a goal of having it up in all states and all medical centers by the end of 2014. However, you know, whether the actual funding will be available for that is not definite. I will, our website address is also going to be on this, and we keep updated information on our website on which of the states have current veteran-directed programs. The VA website is not kept updated quite as often. However, that can be a resource as well, not only for the veteran-directed program, but to give you a little bit more information about some of the other veteran services that are available. So future directions of the VT-HCBS program, you know, the VA, as I mentioned, you know, as far as new opportunities for brain injury specific funding, I know there certainly have been some discussions with NASHA about this, and we found ourselves, our center as well, that contracting process takes a long time. So nobody should think that it's going to happen overnight, because unfortunately it just takes a long time for it to go through all the channels and for it to meet all of the regulations that the VA has for contracting. So, you know, they kind of even call it a swim lane organization, where there are a number of different departments that kind of work side by side with each other. And if you're crossing swim lanes, so geriatrics and extended care manages the veteran-directed program, but of course contracts and financial people manage all of that. So you've kind of got to get both tracks to agree to something before you can get something that both tracks will work on. Increased uniformity. One of the challenges of the program has been that it was kind of implemented as it was being developed. So some of the earlier sites that implemented almost implemented a totally different program, didn't always really reflect that the veteran should be in charge of the program. So a lot of things are, a lot of what's going on right now is to kind of go back, making sure that, you know, we're really trying to target to make sure that younger adults are also getting into this program. It's not just strictly kept with the Aging Network people. We're trying to go back and verify that there are good disability partnerships so that veterans have the benefit of getting full community resource explanations and descriptions. So when they're using their budgets, they're using it, for what's really available to them, not just certain types of services. So, there are a lot of things we're trying to do to help make this program a little bit more uniform, but also a little bit more predictable. And if a veteran moved from one location to another, they could have basically the same program with the same program parameters. The work is really going on in one area too, which is kind of setting up how much a budget individuals will receive. There's a case mix system that actually Minnesota uses that the VA is adopting almost completely, and are going to be using that both to determine a veteran-directed budget for individuals, but also to determine the level of services people would get if they're getting more traditional home-based services and respite through agencies. And this is going to have a huge impact, I think, on the VA to help bring it up a little bit more comparable to some of the more advanced states, and making sure that individual veterans don't have to go into institutional settings but have realistic service provisions in their home. So that's a really major thing that's going on right now. It should be actually implemented within a year at the most, but I think that you'll find it has a very positive impact on veterans, especially those with brain injuries. I don't know why I'm not. I'm really having technical problems here, so I apologize. But that really brings us to the end of my presentation, and I'd certainly like to take questions. I apologize that I'm not able to read the questions on the screen. Carla, do you want to take it?
Yeah, I have a few questions actually for you, Diane.
Okay.
One of the questions is if an agency on aging got a contract to run this program in an area, could they in turn subcontract the day-to-day management of it to another nonprofit agency?
Sure they could, yes. I mean, but of course it would be their discretion to do that. But yes, they can. Some of them do, as a matter of fact.
My next question is, are these services also available for younger OIF and OEF vets with TBI?
Yes, absolutely. And even if people are in the caregiver program, they can also have the veteran directed, but basically what the VA will do is see what the stipend is going to the caregiver, and the equivalent amount of budget will be removed from their veteran directed budget. But the remaining amount they can, purchase items with and so forth.
My last question is, can veterans be in the VT-HCBS program while also being enrolled in the New York State Department of Health's TBI or NHTD waivers?
Theoretically, they could, and this answer has always confused me. So, but what I've been told from the VA is that the VA benefits are an entitlement to people, so they are entitled to these services. I think the VA would probably explore with the individual what other services they were getting to try to avoid duplication, but technically they would be eligible for both. Yes.
And that's an excellent question. I also have another question that just came in. Are there opportunities for supportive housing for vets with TBI in the New York City area, do you know? And I get a lot of questions about supportive housing for vets as well.
Sure. And I just have no idea. Maybe, Carla, you know.
I am actually still working on this. It's really, for me, it's largely about making contacts with individuals that are working in providing supportive housing for vets. So this is very new for me as well. I'm really on ground level with this issue. So if anybody's listening, actually, I would love it if people could email me that have some resources for me. The New York City area, I do have a fax coordinator. I have several actually that usually aid me in that area. But as far as supportive housing, that's an issue that I'm actually currently working on finding more resources, especially in the New York City area and in the capital region. That's the last question I have. I don't know if anyone else has any questions, if they would like to, one more came in. Which parts of New York State have this program available, and are there any formal barriers to any region or county that wants to start up?
Okay, New York has been a little bit of a unique case. Right now it's active in Syracuse, and one of the counties served by the Albany VA Medical Center is just getting started, probably even this week. One of the barriers in New York has been that you often have what's called an agency with choice model, and the state is obligated to use the rates that are set by Medicaid for those agencies, and those rates don't really fit within the amount the VA is willing to pay for administrative oversight for the program. So that's what the barrier's been, and the State Unit on Aging has been working closely with some of the financial management services providers and the agency with choice providers to get it up and going. But anyway, the goal certainly is to have it statewide in New York, but it's just been kind of a county by county issue and trying to get the rates within the range that will be acceptable.
If anyone would like to ask any questions, we have about 10 minutes left. If we have to end early, that's okay. But I do want to provide a little bit of extra time for anyone else who would like to ask a question.
And I've got your slides, Carla. So.
And Diane, you said you did have another slide. I know we have the end slides.
I know. And my, I see what's happening here. It should be okay now. Okay, let me go into yours here.
So just a little bit about the Brain Injury Association of New York State. For those of you who are not familiar, we are a statewide nonprofit membership organization that advocates on behalf of individuals with brain injury and their families. Here is our contact information. We do have a family helpline as well, a toll-free number for that. And this is all available on our website, www.bianys.org, which is also where we will be posting the recording of this webinar. We are attempting to hold monthly webinars. We do have another scheduled webinar. It's for May 3rd, a Thursday, 10 a.m. to 11:15. Our presenter for that is Dr. John Letty, and it's actually titled Getting Ahead of the Game, New Approaches to Concussion and Post-Concussion Syndrome, Evaluation and Treatment, for those of you that are interested. And please, if you like this webinar, like us on Facebook. We are doing the Facebook networking. I do have a couple questions that just came in, Diane.
Okay.
One is, can people in other parts of New York State go to the Syracuse area to access these services?
It's because everything's basically done in the home. Unless you move to that area, it probably would not be realistic, because the Area Agency on Aging in Syracuse is the one doing it, so they would have to travel. I mean, you could certainly ask if they would be willing to service you if you live somewhere else, but it would probably be up to them. Syracuse, the VAs do in some cases kind of share referrals back and forth. I'll give an example of that. New Hampshire and Vermont have different methods of how they do service delivery under their state statutes. So all of the New Hampshire veterans are going to be served by the New Hampshire VA Medical Center in Manchester, even though usually some of the northern New Hampshire veterans are usually served by a Vermont Veteran Medical Center. So it can be done, but you certainly would have to see if that local area agency on aging could do the traveling to go to that veteran's home.
And another question that just came in, what type or kinds of community organizations service TBI patients?
Through the VA, do you mean? I'm wondering.
I'm not sure. Deborah Phillips asked the question. Deborah, if you could just elaborate. I do have another question too. Is there any likelihood of the Bath VA getting involved in this?
Bath, is that in New York? I'm not familiar with it.
Yeah, that's in New York. That's a tricky question.
I mean, it's certainly possible. As I said, the VA really wants this active in every VA medical center by the end of 2014. One of the delays in getting it up and going in given locations has been how much money has been set aside. They use what they call special funding for this right now. As things go forward, we think that there's going to be a quicker uptake on this, but of course nobody can really predict the future. If you I mean, advocacy is always a good route to go. If you know veterans who are really interested in the program in a given location, the more vocal you are about saying you're interested, whether it be to the VA itself or to the even to the aging network people, who in many ways are the ones who have the heavy lifting on this. They're the ones who have to develop the program and everything. I think that that's probably one of the ways to get moved up in the list of who's going next and who gets funding next, because it's really come from the ground up in terms of, people in certain areas will say, boy, we really want the program. And if they let that be known, then that gets up to the central VA and they put it high on their priority list. So I would definitely recommend advocacy to get it in locations where there are veterans who particularly would want it.
Another question that came in, are there currently any partnerships that you are aware of with community partnering with independent living centers?
There, in Minnesota, it's an independent living center that does VT-HCBS. It's actually one out of the Sioux Falls, South Dakota VA Medical Center, but it's for some of the rural counties in Minnesota. And they use the network that works in their, basically their state participant-directed program. And it happens to be an independent living center. So they're the ones that do all of the support counseling and so forth. I don't know of any other offhand.
We did get a little bit elaboration on that question. So the original question was, what type or kinds of community organizations service TBI patients? And then she added to it, not necessarily tied to the VA, community organizations that a person with a concussion even can go for assistance. Where can they go?
I mean, I don't think I have particular expertise in that. I don't, Carla, if you'd like to, or somebody from your...
I think this would be a great question to email me, Deborah, because I just need to know a little bit more about what kind of services. I mean, I think the Brain Injury Association of New York State is a great resource. So if you could email me that question, I greatly appreciate it, and then I could try to find you a better answer, a more in-depth answer, the right answer. My email is on all the automatic emails you're getting from GoToWebinar, but I'll say it. It's a long last name. I think it should be showing when it says who's talking, so that's my spelling. But my email is C as in Carla, and then my last name, GIOVANNIELLO. And I do believe it should come up as who's talking. And it's at BIANYS.org, and that's B as in boy, IANYS, like New York State. .org. So if you could please email me that question. Again, I'd appreciate it. We do have another one in. We're running out of time. We do have about 3 minutes left. So if you have a last minute question, please get it in now and we'll do our best to answer it. But we do have a few here. If we as an independent living center are interested in becoming involved with providing this and other types of VA services, who would be a good contact or resource?
I think the quickest way to get involved would be to work with your local aging agency, because right now they're the only ones that can contract with the VA for this particular program. In general, though, if you're looking at providing veteran services, the division I work with the most is the geriatrics and extended care, and this is in the Veterans Administration Central Office in Washington, D.C. And you can certainly, through the website, you can go through. The person I work with mostly his name is Daniel Sheps, and I know that he talks with people all the time who have an interest in serving veterans. So he might be a good person to start with. I don't have his contact information offhand, but I can send it to Carla, maybe to send it to you, or feel free to email me directly if you'd like to. And my email is Kayala, Kayala, at bc, as in Boston College, .edu.
Okay, that looks like all the questions we have. If anybody thinks of any last minute questions, please feel free again to email them to me and I will make sure they get to Dianne. Dianne, thank you so much for presenting today. I know I found it very informative, so thank you.
Well, thank you. Appreciate it.
And I will be ending the webinar. Again, if anyone has any questions, please feel free to email me. Thank you all for coming.